Why does it have to be in the summer? It's a horrible summer. I'm like, I'm like, maybe in the fall, I'll be ready. Yeah, I feel like in the summer, it's like, I already work, and then I'm doing this, like, I need sometimes to do this. Yeah, it's horrible. Are you full-time or part-time? I'm like, right, I have 3 classes, so I'm like, just meeting full-time. Are you in the dual program? I'm thinking about it. And I was like, I think I'm gonna drop it. I don't think we're gonna use it. Field path. I don't know. No. Once I take this exam, it's gonna either like tank my grade or keep it where I'm at. Everyone just looks really strong. I'm not in fire. I mean, just biostat and how'd you do the bio sticks? Yeah, did you fail too? Yeah, I failed. It wasn't bad. It wasn't that bad.
I just remember being in school and after a pharmacology exam, people out in the hallway puking. Yeah,
Oh, school shouldn't be.
yeah.
Like, they're just.
We'll give them like until 5 minutes.
That's good. No problem.
Yeah. He's like, take 5 things. I think next summer. Me too. At least we'll all be at tomorrow.
At least I know that.
Maybe you'll
I'm
be.
sure we can do
Maybe.
No, we don't. It was in the summer.
You know, I know.
Summer. Right? It's all summer.
Yeah, it's not. I'm not, I was like, maybe I would.
On your final study,
Yeah.
it's 5280. Are you sure?
What do you get? I don't.
Yeah.
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 She probably just messed up. Yeah. Cause I think that's one.
Yeah, we only teach buttons.
Well,
It's just the way it works.
can we change that?
It's a very stressful summer.
We'll have next year.
How many people
I don't feel like
fail?
they'll fail anybody.
No one, either like they can't fail everybody, so that's what we're all thinking. So why don't we like all commit to failing?
You know, I taught last year, we didn't even fail last year.
Oh my God.
I think, you know, but it's always like maybe 1 or 2 at the most after class. You might have to remediate at the end of the class. But
What do they
Are
do
you-
when they remediate? They
But
just
they
take
take
just
a comprehensive file.
It's this whole thing.
Yeah.
Are you sure Dr. Toma's gonna help me out?
Yeah, it's amazing. The Toma miracle happens every year. She's teaching biostats. People just tank the whole course and then they do fine.
How?
I don't know.
How do you know?
Because I don't know. 5 years now. I watch it every
You
year.
told me I'm gonna be fine, now I'm nervous.
It's the
No,
Toma miracle.
you feel better.
She's
Trust the
she
process.
curbs it.
But.
Because you're all in the same boat.
We're all failing.
Yeah, so she'll just push everybody's scores up. Frankly. Oh, good. We have one more and then we'll get started, guys.
Like, we don't have remediations for biostat. That's
No,
the thing. I was like so worried.
I failed that test and
I was, last time was. hard.
Hi, Jenna.
you
Can you
did
hear
okay
us?
on this one.
It was like. I was so worried.
She's muted.
That's what kept me out of master's
Yeah,
program was
for
the statistics. I
Okay.
said they should call it sadistics, you know, I'm like, no,
Tough class.
yeah,
If you don't have that, you know, it's like a certain part of your brain that you use statistics.
I haven't taken a math class since I've been like 17. So it's just like throwing me for a whirlwind right now.
Yeah, it's all math.
yeah, you
Yeah.
have to practice.
get out of,
Math,
get out
math,
of.
like, I don't know
Yeah.
how to do anything.
Okay, we'll get started. We have 2 people on Zoom, 2 people on Zoom. We are recording. One other person is but in any event, glad you're here. We have a few still missing one. We can't do one. And because a couple of reasons, this module is so important. You're going to use it in practice a lot. If you're in the hospital, you're going to be looking more at adult vaccination as well as the pediatric hospital. And making sure everybody's got their pneumococcal vaccines and shingles vaccines, that kind of stuff. Should be doing that. And then if you work in primary care, it's lots more. And then you got the teenagers, you know, you're going to be thinking about Gardasil and encouraging HAP and getting people caught up. People's ways you see this in practice is somebody's coming in and we're going to start their nursing program. They got to come in with titers. The titers come in low, then they got to go through a immunization cycle. So it's something very usable. And the other thing is, you know, we have in this course, and there are a lot of vaccine questions on it. The other thing I've already preached to you, and I don't know if I percent this is said, but and on your certification exams, you will have questions about vaccines. And I don't recall in mine, I took the AANP's family certification exam. They're mostly about concepts. They're not so much about, you know, at 6 months, you know, pick the right vaccines. You get so you know them, and it's good. And I think to get through your PEDS class, I think I had to, at Wayne, you have to like know, you know, when our MMR is getting there. And I do this all the time. I never do it from memory ever. I always use a reference because it is too confusing. Do you agree?
I agree.
All right.
Don't depend on your memory
So you will screw it up.
because it changes.
Oh, yeah, and
Harm
things
them.
do
You
change.
can harm them.
Yeah, things change. Yeah.
So when it comes to our exam, then will it be more concepts? instead of
Yeah, I don't
memorization?
actually just split
Okay.
up the cycles. No, I would never do that.
Thank you.
Because I'm trying to influence you to not do that in practice.
Yeah.
I'm not going to make you do that on a
Thank
test,
you.
but you may see some pretty easy ones on a test.
Okay.
You know, like how old, you know, for example, Gardasil. How old can you be to still get Gardasil? How
Like
old?
20.
Gardasil's
Old.
for HPV.
Oh, up until.
Yeah, that's,
No.
you shouldn't have that funny look on your face because how many
No.
times have that changed in the last 5
Yeah,
years? 3
it's
times. I think.
changed. Yeah.
Up to 40
Nope.
something.
40.
Oh, I thought it was 40.
Yeah, start out at 21 for different for men and women, yada, yada, yada. When I
21,
started,
26.
21.
No,
I
you couldn't
thought
give it
that was
after
like
21. They didn't think there was a benefit sufficient to the risk to give it after 21. And now we're out to 40.
Because my doctor was like times taking for me. So I was like, oh, I was like 18.
Well, it would have been, you know, I mean, you gotta have an interval,
Yeah.
6 months, I think. is the
Yeah.
interval, between.
It follows the sort of like the hepatitis B schedule.
Yes,
You know, if you get the 3 doses, you get the first dose, then a month later, 1 or 2 months, you get the second, and then the third dose in 6 months.
if you're using, now we have
Right.
two vaccines.
Yes,
One of them's 3 dose, one of them's 2
Yes.
dose, so boy, it gets complicated. And that's why you always pull the Micker, get the schedule and look at it in a quiet place so you can figure it out.
and
Okay,
there's actually an app too that you can download from the CDC,
I use
which
it.
is very good.
It's on my phone.
Yeah.
Anybody wants to see it?
Yeah.
I've got it right here.
Yeah.
I would like to introduce to you Kay Fradeneck. Kay is the retired and coming back to help out Wayne County Health Department Coordinator for immunization. And we are so appreciative of having you here.
Thank you. Thank you for having me.
I'll just-
Okay. My name is Kay Fradeneck. We're doing the vaccines across the lifespan module. This is a module from the state of Michigan. This is through their immunization program. So I'm just going to follow, you know, this is the module that I would go out and teach to professionals. And when we could, we would give CEUs. Right now, we can't. So I apologize for that. What I need to tell you is that I receive no commercial backing or money to prevent this information. I don't get paid by anybody to do it. So no commercial support. And today, let's see, we're going to talk about some off-label uses for the vaccine. What an off-label use is that when the drug manufacturers do the clinical trials, they test the vaccine on children or adults between this age and this age, so that when it becomes licensed by the Food and Drug Administration, it's licensed for the people that they tested the vaccine on. So it would be, say, for instance, the Gardasil that we were just talking about. Initially, the vaccine was licensed for people 11 years and older up to age 21. And then as time has gone on, it has been expanded. The use has been expanded. So anytime it goes beyond like that initial licensure time, that is considered an off-label use. So because HPV can be used for kids down to 9 years of age and up to 40 years of age, anything above or below those recommended ages in that initial clinical trial is considered off-label. So when you hear somebody talking about off-label use, that's what they're talking about, okay? The use of trade names is not an endorsement of any particular product, but you know, as time goes on, you will learn the product by its trade name and not necessarily by its antigen, although you really should know what the antigens are in the vaccine. And again, no commercial support has been used or received. We're going to talk about a little bit about vaccine storage and handling. This has been emphasized. The CDC did a research study back, I think it was 2010, where they had the Inspector General go out and look at how vaccines are being handled in offices, in practitioner offices. And they found that the vaccines were being handled in such a slip-slap manner that they were concerned about efficacy, because the vaccine, when it's tested, it is stored in controlled refrigerators at a controlled temperature to ensure that it's effective. And when they went into doctors' offices, they would find that they had little dorm-style refrigerators and they were keeping their vaccine in that, and other refrigerators and no thermometer and no monitoring and stuff like that. So initially, that was the thought of why there was so much breakthrough disease with pertussis, even though people were receiving, you know, a full line of pertussis, a DTaP or pertussis containing vaccine, and they were questioning why, you know, we're giving people all this vaccine, why are we seeing so much breakthrough disease? And that was initially, and it probably did have something to do with it, you know, because if the vaccine is not handled the way that it is supposed to be handled, it's not going to work the way you want it to work. So, and we're going to spend a little time talking about that and how that can open you to liability. So it's really important, you know, if there is a breakthrough case of something that you immunize somebody for, and a kid comes down with something or an adult comes down with something, and, you know, everybody's got, you know, Sam Bernstein on speed dial, so they can sue you. And what they will do is they will ask for all of your temperature logs and all of your records to see how you are monitoring and handling that vaccine. So it's an important thing. And, you know, as the immunization coordinator for Wayne County, that is something that we went out and we inspected people's offices to make sure that that's what they were doing. So, but, you know, not every doctor's office does that. And it's important as a practitioner that you incorporate that into your practice to ensure that your patients are receiving, you know, a good standard of care. We're going to talk about the recommended vaccines for children, adolescents, and adults, and we're going to identify the 6 steps in the immunization process. So, what the CDC recommends for storing vaccines is a standalone refrigerator that is purpose-built for vaccine storage. That is a pharmaceutical grade refrigerator. And you have a digital data logger. What a data logger does is it captures the temperature of the refrigerator 24/7, so that it is monitoring the temperature in that unit at all times, whether you're looking at it or not. In the past, in the years past, what would happen is that people had, you know, a thermometer in there. They would come in the morning, they take the temperature, it looked fine, they would go and do their thing. And then in the evening, come back and take the temperature, it looked fine, then they would go home. They had no idea what went on, you know, between the 8 hours during the day when the office is open or at night. so that if that unit was getting too warm or too cold, there was no way of knowing because that particular thermometer didn't capture that information. Well, the new data loggers that they have Wi-Fi ones, and I mean, they're pretty sophisticated. They can monitor and capture and notify you if the vaccine temperatures are out of range. So that's something that they want you to be aware of too. And also to know what the temperature ranges recommended for refrigerated and frozen vaccine. So refrigerated vaccines, anything that is supposed to be handled in or stored in the refrigerator is between 36 and 46 degrees. That is for all vaccines. In the freezer, it has to be at 5 degrees Fahrenheit or less. So the only thing that is kept in the freezer is the live vaccine, which is the varicella and the chicken or the MMR vaccine. Those are really the only ones that you have to think about. If you can remember, you know, that has to be stored at 5 degrees Fahrenheit or less. Everything else goes in the refrigerator at 36 to 46 degrees. So really all you have to know is the live vaccines and everything else is 36 to 46. The other thing is that they want you to monitor those units with a min and a max capability. So you will come in the morning and you will check the temperature. Then you will hit this button. It will tell you as warm as the unit has been, and then you will hit the button again, and it will tell you as cold as the unit has been. And as long as it's within that 36 to 46 degrees, you don't have to do anything. But if you find that it's been out of range, you need to call the manufacturer to see if the vaccine is still usable. So, and some of them are kind of fussy. Influenza, surprisingly enough, is not tolerant of a lot of temperature fluctuation, and also MMR, although MMR can also be kept in the refrigerator. So yeah, it's kind of crazy. It's better to keep it in the freezer because then if it goes out of range, it won't ruin it. But if MMR goes above 54 degrees, it's toast. So it just depends, and all of the manufacturers have their own standards. That is the only standard that you're going to follow is the manufacturer. So nobody else is going to say, you know, like, yes, this is okay, or no, it's not okay. You have to call the manufacturer and they will give you the data to say that yes or no, it is or is not usable. Make sure that you have somebody in the office that knows how to manage the vaccine, that knows how to use the thermometer and is consistently taking temperatures and following the recommendations for storage and handling, and that they're rotating the vaccine so that the longest or the shortest dated vaccine gets used first. So you want to push that to the front of the refrigerator. And if there is a loss, which sometimes happens, we've had instances where we've called the state and we say, can they be forgiven from this loss? And they say, well, no, because they use the longer dated vaccine before the shorter dated. So they really push you to use, you know, make sure that you're rotating and using your shorter dated vaccine first. Make sure that you keep the vaccine in the original box. Light does affect the vaccine, so you never want to take it. Like, I've gone into people's offices where they've opened the boxes and dumped all the vaccine in a bin. You never, ever, ever want to do that. First of all, light can damage the vaccine, especially like varicella. Varicella is very light sensitive, so you never want to take it out of the box. Or, you know, there's a possibility that you can mix lot numbers and stuff like that. So if people are just dumping stuff in bins, you know, things can get mixed up. You don't want to do that. That's not good practice. Make sure that you keep it in the box. And draw the vaccine at the time that you're going to use it. I thought I was going to have a heart attack. One day I went in to do an inspection into an office, And the practice had these cups, literally like, a drinking cup. And they had syringes drawn up in all of these cups. And on the cup, there was a label that said what it was, but that was as good as it got. Now, I don't know about you, but once you take that out of the cup, how do you know what's what? And maybe you put it in the wrong cup or something. No, 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 no. You never do that. Never, never, never do that. So, you would be surprised the practice that, the broad standards of practice that we've observed over the years and what people do. It's kind of crazy. So you only want to use, as one syringe, you draw it up, you don't mix vaccines ever, never. And anytime you are given a diluent with a vaccine, so some vaccines have their own diluents, you only use the diluent provided with the vaccine. You can't just grab normal saline and use that. You cannot.
It comes with it.
Mhm. If the manufacturer sends you a diluent with the vaccine, that is the only diluent you can use. So like MMR and varicella have their own diluent. There are certain brands of Hib vaccine that have their own diluent. There are some Pentacell vaccine that has its own diluent. So those you can only use with that vaccine and nothing else. If you use a diluent other than what's provided by the manufacturer, it's an invalid dose. It doesn't count. And I'll tell you what, you want to make parents mad, call them up on the phone and tell them that they have to bring their kids back and be revaccinated because you made a mistake. Parents aren't, excited about bringing their kids in to get shots in the first place. And then to have their provider make a mistake, that's one thing you can really, ruin your reputation with the parent by doing that. So make sure that you're not making those kinds of mistakes. And if you're employing like medical assistants, make sure that they understand how to do it, because they don't have, the education that we all have. And a lot of times I think that, I don't know what these offices are thinking. They bring these people in, they have no education, and then just throw them in and expect them to know how to do this. It's pretty scary. So know which vaccines need to be reconstituted. Now, one of the things that I have given you, this is the vaccine storage and handling chart. This we recommend that you post on your refrigerator, and this tells you exactly what vaccines need to be refrigerated, how they need to be refrigerated or frozen, so on and so forth. So when we are visiting a VFC person, what we will do is we will make sure that they have this posted on their refrigerator so that if there's any question, they can refer to this chart. So the next thing is the vaccine administration and preparation. We tell practices to put this up in the prep area so that if there's any question about administering or prepping the vaccine, that they have this available for their reference. Okay, and then this is a great reference too, is what diluents go with what vaccine. So these are all things, resources I'm hoping that you will use in the future, because this is going to help you not make mistakes. Okay. There is a, yes, go ahead.
How expensive are vaccines?
Oh my God. Well, a dose, let's see. Last time I checked, a dose of one of the combination, I think it was the MMRV vaccine, was over $200 a dose. A dose. And there's 10 doses in a box. So that's over $2,000 in a box of 10, and the box is like this big. That's why, when you think about that, if you're in a practice and the expense is phenomenal, the amount of money, especially combination vaccines, like the Menactra now, Menveo, those vaccines, the Men B vaccine, those all are so expensive. So, you know, try not to waste them, because every time you do, that's money out of your pocket. You know, and now, like, I mean, hepatitis A and MMR never were that expensive, but now the prices are going up. So everything, I mean, it's like anything else, I guess, you know, it just goes up. Doesn't come down in price, just goes up. The other thing is there are modules. I was telling your instructor, may I call you Bud? Is that okay? Okay. So I was telling Bud that on the CDC website, there is something called You Call the Shots. If you go onto cdc.gov and you, in the search tab, put in You Call the Shots, these are modules that you can take. And for every module that you complete and take the test, you get one CEU. So, I mean, you get CEUs, that's a good thing. It covers, I mean, there's one for pain in there. It covers your pain requirement. You know, there's really good information. There's also like videos that you can watch, and it actually shows you how to administer vaccines. You know, I mean, it's hands-on where you can actually see. So these are great resources to take advantage of. Never try to fake your way through. I'll tell you a story. Now, you remember back in H1N1, that was that little pandemic that we had in 2010. It was nothing like this one, right? So that's when I started the job in the VFC program. I began on a pandemic and I left on a pandemic. So I came into the program, and the only vaccine for the H1N1 was available was the nasal spray. That was the only vaccine available at the time. They were still developing the injectable. So the nasal spray has specific parameters, who can get it, who can't. It can be given to people 2 through 49 with no underlying medical conditions. So you can't be an asthmatic, you can't be a diabetic, you can't have heart disease, all this stuff, right? And, you know, you have to squirt one in one nostril and squirt one in the other nostril, right? So we get the vaccine, it's like gold. And we're distributing it out. We're trying to get it out in the community and get as many people vaccinated as possible. So I send it out to this practice. I'll only tell you it was in Livonia, which was shocking to me. And the persons that had this practice, I don't know what the heck they were doing, but they gave 100 doses of vaccine in one nostril. And then what they did is they labeled the syringe that it comes, the applicator, because it's not really a syringe, and they put it in the refrigerator, and we're having the patients come back a month later for the second. Oh, oh my God, that is what, but I didn't say that. I said something much worse, because it, you know, 100 doses, there's 100 doses wasted right there, number one. So I call the guy on the phone and I'm like, first of all, why wouldn't you read the directions? All you have to do is pull the insert out of the box and open it, and it tells you how to administer the vaccine. Why would you do? I mean, yeah. So I'm telling you, if you can imagine, we've had people, I kid you not, draw up rotavirus. Rotavirus is oral, okay? Comes in a little thing, you twist it off, you squirt it in the baby's mouth. That's it. Well, there's one product from one company that you have to mix with a diluent and then squirt it in the kid's mouth, right? for whatever reason, I guess they didn't understand because of course, God forbid, you should open the package insert. They injected the rotavirus in the kid's leg. Yeah, in the kid's leg. So if you can imagine all of the scenarios that can happen with people misusing vaccine, that's what we've seen over the years. It's been crazy. Anyway, I digress. So you need to know which vaccines need to be reconstituted and how to reconstitute them. That it's very important that you understand how this thing is supposed to be used. And if you don't know, use the resources, right? But you know, there's stuff that I'm giving you. There's something in here also. These are absolutely the best. So I put these in here. They're called Quick Looks. This is something that's been developed by the Michigan Department of Community Health. And basically what they've done with the Quick Looks is they've taken the package insert. This is like the Reader's Digest version of the package insert. They've compressed everything down so that you can quickly look at this and get all of the information that you need at a moment's notice to get that vaccine if you have any questions. So I would recommend that you use these, you know, in your practice because it's very, very good. And there's one for every vaccine. Now, if you reconstitute a live vaccine, it's important to know that you have 30 minutes to use it. Anytime, well, actually, any vaccine that requires a diluent that you need to reconstitute gives you that 30 minutes, not just the live. I have to say it, any diluent, because anytime you reconstitute it and take it out of the refrigerator, it begins to degrade right then and there. So you have 30 minutes to use the vaccine. If you can't use the vaccine, you need to put it in the sharps container and discard it and count it as a loss. But 30 minutes time for any reconstituted vaccine. The Shingrix, it says you can use within 6 hours. That is also reconstituted. That's right in the notes here in the minuscule tiny print that you can't see. There's also something called a beyond use date, and it only applies to some flu vaccines. It doesn't apply to every vaccine. Now, I know there's certain agencies like Henry Ford has a policy where when they open a vial, they date it and then you have to use it within 30 days. And if you don't, then they come and take it out of the refrigerator and dispose of it. And they've wasted a lot of polio vaccine doing that because polio is guaranteed to be efficacious through the expiration date on the back of the vial. So even though their policy says you have 30 days to use a punctured vial, that's not true for the VFC vaccine. And we will come after you if you waste VFC vaccines, so don't do it. So yeah, so make sure that you understand the beyond use date. There is, and I can't remember now which, does it say blah, blah, blah? Because it's one of the flu vaccines that flu cell vax and afluria per package insert. Once the stopper has been punctured, discard the multi-dose vial after 28 days or 20 punctures into the vial. So, you have to be aware of those things too, is that, each vaccine manufacturer has certain rules about how and when to use their vaccine. That's why it's really important that you guys take advantage of, like, the Michigan Department of Community Health has vaccine conferences every fall. And they're all over the state. So, wherever you live or whatever's convenient for you, it's really important that you go to those, because that's where you get a lot of this information, the little nitty gritty stuff. And it's only $50 and you get like 6 or 7 CEUs to go. So it's it's called the MDCH Regional Immunization Conferences. So those are very good. Also, what the state wants you to know. Is your vaccine coverage in MICR. Do you know what MICR is? Anybody know what MICR is? Have you ever gotten one of these? There is a data system in Michigan. It's called the Michigan Care Improvement Registry, MCIR. And what they do is that in the state of Michigan, there is a law that says that every physician that is giving vaccines to persons under age 20 has 72 hours to get that information into this registry, the Michigan Care Improvement Registry. And that's so that anybody in the state of Michigan, no matter where they're getting vaccines, you can look up this record and know what your current immunization status is. Now, keeping in mind that MICR is only as good as the data that's put in. So if you have a physician that is not putting data into MICR, then if you pull it up, it's not going to have the most current data because the doctor didn't put the information in. So you really, that's why it's important when somebody comes in for shots, you say to them, do you have your current immunization record, any kind of paper records or things that they've gotten, so that you can compare what they have to what is in MICR. And if it doesn't jive, then you would go in and update MICR to make sure they're both matching so that everybody has the same information. So, and what you would do, if somebody comes to your office, you're going to pull this up to assess their record to see what immunizations they need. Through this system, this particular system, there's a lot of things that you can do. And one of them is to track your practices immunization rates. So you can run reports, and MICR will also print letters and send out postcards and do all kinds of stuff to help you improve. Like there's something called the birthday letter that they send out, or the kindergarten roundup letter. You can go into MICR and say, I want kindergarten roundup letters. And based on your roster that you've put into MICR, because every time you go into MICR and enter a kid, that kid comes over and is now on your roster. What MICR will do is it will look for all the kids that are turning 5 and will print letters for those kids to say, hey, you need to come in, you need these shots. So there's a lot of things that you can do with MICR. It's a very useful source. So I highly recommend that you use MICR to help you in your practice. Okay, let's see. So this is data, Michigan data from 2021. And you can see at the beginning, it's 77% that the kids are up to date with 1 hepatitis B, which is what they want them to have. But as time goes on, you can see that it falls off. And that, in Michigan, we're not doing such a great job of immunizing children. And part of it has to do with immunization hesitance, that there's a lot of people now that are opting out of getting vaccines because they're hesitant about giving those to their kids. So just keep that in mind as something that you're going to have to deal with, unfortunately. Okay, so the immunization process. There are 6 steps to the immunization process. You're gonna hold the record and you're gonna assess the record and determine what the child needs. You're gonna check the current recommended schedule. So what I've done is I've printed off the current immunization. I printed these yesterday. So this is as of yesterday for the children 0 to 18 and then adult 19 and over. So this tells you, what is needed for each age group and so on and so forth. So those are the most current schedules, recommended schedules. So you're going to look at the schedule to see what the kid needs and what they're missing. You're going to ask the screening questions. So screening questions, the purpose of doing a screening question is to eliminate any contraindications. So you don't want to give, a vaccine to a kid that is sick, like with a high fever or something like that. Mild illness, it is permitted to give. So if a kid comes in and has like a cold or something like that, you can immunize. But, if a kid is sick, really sick, sometimes they'll hold the vaccines because they don't know if the kid is really getting sicker or if it's because they're running a fever because they just had shots. So, that's why they would hold the vaccines in that instance. You're going to educate the parent or the client about the vaccines that they're giving. You're going to administer the vaccines and then you're going to document it in MICR. All right. So again, you're going to look at the Michigan Care Improvement Registry. You're going to check your records to make sure that they match and then update it if not everything is in MICR. Check the current or recommended schedules. And this is kind of how this works. If you look at the schedule, it's color coded and it tells you, so the yellow part is the recommended ages. So that's when you would see children receiving those vaccines. The green part is the catch-up. So if you have a kid that is not up to date, you would look on those green columns to see if there's something that they need. The purple is for certain high-risk groups because now they have schedules for you to determine if you have a high-risk individual, what vaccines would be needed for that person. The little checkered thing is recommended vaccination can begin in this group. And the blue is the recommended based on a shared clinical decision-making or no immunizations are recommended. So those are all the color coding that is in the schedule. And if you look at it, that's kind of how it's laid out. So the catch-up schedule, basically what the catch-up schedule are the minimum intervals between doses. So if you have a kid that maybe hasn't had shots for a couple of years and has fallen behind, this would help you catch the kid up and get them up to par with their immunizations. So like for hepatitis B, the minimum intervals there are 4 weeks between doses 1 and 2. There are 8 weeks between doses 2 and 3, and then 16 weeks between dose 1 and 3. So that's how the catch-up schedule, just remember that it's the minimum intervals allowed until you get your kid caught up, or your person, your adult, no matter what. We have a lot of kids come from other countries, and a lot of them have incomplete immunization records, and a lot of times we have to figure out what they need to get caught up. So these are very useful in those situations when you have kids that come in with an incomplete record. This particular one is based on underlying medical condition. And it tells you like what vaccines you should consider giving to individuals that have these underlying medical conditions so that they would be appropriately protected. There is guidance also in determining how to catch. This is a more expanded catch-up schedule that you can get on the CDC website to help you determine what vaccines are needed for a kid that comes in with an incomplete record. So, and if you look, it has the website right there. This is the indications by medical condition. So pregnancy, what vaccines should be given during pregnancy, immunocompromised people with HIV, kidney failure, heart disease. So all of these conditions, it helps you to determine, you know, in addition to maybe a tetanus shot, what vaccines this person should get to help protect them with these underlying medical conditions. This is the adult schedule, which would be this one here, this blue one. So that's the adult schedule. It's laid out the same way. The ages are at the top, and then the vaccines are along the outer column. And it just tells you, you know, what vaccines an adult should have. And the same thing with the color coding, tells you, you know, the recommended, the high risk group, and then the vaccine based on a shared clinical decision making. We'll talk a little bit about that when we talk about the MenB vaccine. Provides more information on adult recommendations based on risk condition. I love this. I think this is a great idea that they have this because, you know, when you have an adult come in that has some of these underlying medical conditions, it's important to give them vaccines that are going to protect them. You know, like with diabetes, you know, we want to give the hepatitis B vaccine. What they were finding, they did some research and discovered that especially in group homes or long-term care facilities, that the machine was not getting cleaned properly, you know, the glucometer when they did blood sugars, and that people were getting hepatitis B because of them not using this equipment properly. So because they were seeing an increase in the number of people coming down with hepatitis B in that diabetic population, they recommended, they were like, well, maybe we should give this vaccine so that if they're in a situation where they're exposed to hepatitis B because of whatever, that they would be protected. So that's one of the newer recommendations with hepatitis B, is that you have an adult with diabetes, you want to make sure that they're covered. Okay, so there are two types of vaccines. There are attenuated vaccines, and those are live vaccines that have been treated in a way so that if you get the vaccine, it's not going to make you sick. So like the measles, mumps, rubella, varicella, the old Zostavax, the rotavirus vaccine, those are live vaccines. And they're treated chemically so that when you get them, you don't get the disease, but your body reacts to them in the same way as your body would if you had the actual disease. So you get very good immune response. And that's why you only need 1 or 2 doses. The reason that they give the 2 doses is because about 5% of the population does not react to the initial dose. And instead of testing everybody to see who did or didn't react, they just give a second dose to everybody. And that's to cover everybody and make sure that they have the 100% protection. Live vaccines are very effective. And, you know, you don't have to have a booster dose over and over and over again. You just need the 2 doses. The important thing to remember about live vaccines is that you never want to give them to a pregnant woman or somebody who is immunosuppressed, because it could harm them. So those are the contraindications for live vaccines. Inactivated vaccines cannot replicate or cause disease because how they're made is they're like, you know, on the surface of a virus, you have surface proteins, and that's what your body learns to recognize, you know, your immune system, and that's how you build immunity. The thing, I'm going to show you this too. The thing with inactivated vaccines, like the first time you get an inactivated vaccine, you might have this much of antibody in your blood. Then the second time, you might have this much, and the third time, and the fourth time. And it isn't until you meet, you know, this point right here that you have full immunity. And usually, like with the DTaP, you have to have 5 doses for a baby. So, you know, the first time, you know, you have a little bit of immunity, and then that's why they give you that booster shot at 5, and that's so that you have that full immunity to the disease. If you don't have all of the doses, you're not going to have full immunity. And that's why it's important that you make sure that you're following the schedule and you're doing it, you know, according to the pharmaceutical companies, because they've done the clinical trials and they know how well your body is going to respond and build antibodies. So a lot of parents get really upset about their kids coming back again and again and again. They don't understand. Well, it's because they don't understand the science and how the vaccine actually works. Because this is something that's only using a little piece of the surface protein, and it takes a long time for your body to build full immunity, you have to have several doses. Whereas in a live vaccine, you know, the first dose, really 95% of the people have full immunity. And after that, you know, they give the second dose just to make sure that everybody has reacted to the vaccine. Let's see. So the inactivated, anything other than MMR, MMRV, rotavirus, and the flu mist, those are the live virus vaccines that are on the market. Everything else is inactivated. And so, all right, so here's the thing. How many times have you heard, I'm not getting the flu shot. The flu shot gave me the flu. Have you heard that? All the time. It is not possible for that to happen because they do not use the whole virus in making the flu vaccine. They only use a surface protein. And the way I like to look at it, it's sort of like a mug shot. All right. So a mug shot is a picture, right, of the bad guy. And that's what vaccines do. You get the mug shot so that when your body comes into contact with the real bad guy, it recognizes it and fights it off, right? That's how vaccines work. Inactivated vaccines are such that you only get a portion of the surface protein, none of the internal workings that can make you sick. The reason that you feel sick is because you're having an immune response. Your body is recognizing the antigen and building immunity to it. And that's a good thing. If you have a healthy immune system, you're going to have a good response. You're going to run a fever. You might have a headache. You might feel crappy for a day or two, but it goes away because your body is finished doing what it needs to do. That's the sign of a good immune system, not the sign of the vaccine making you sick. It's, you know, you're doing what you're supposed to do. And because we as practitioners have failed to educate people about what to expect when you get a vaccine, you know, people left to their own selves will make up stuff, you know, if they, I mean, that's how it's human nature to do that. So, you know, that's why people have misconceptions, because they don't have the correct information. They had the correct information, they wouldn't have to resort to misinformation. So it's really important that you, as a practitioner, educate parents what to expect when their child or themselves gets a vaccine. And I always tell people, you may feel blah, 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 blah. You know, if you feel this way, put a cold rag on your arm, take some Tylenol, you know, rest a bit, it'll pass. It's a good sign. Okay. So we're going to talk about hepatitis B. Hepatitis B is spread by contact with infected bodily fluids. And like I said earlier, unfortunately, blood, unclean surfaces, and hepatitis B is one of those viruses that can live indefinitely on a surface that has not been cleaned properly. So even though it appears clean, if it hasn't been disinfected and somebody that has hepatitis B, their blood or bodily fluids have contaminated it, it can stay on that surface for indefinite. If you reactivate it by liquid or something, you touch it, rub your eye or whatnot, you know, you can get hepatitis B. We get a lot of parents not wanting to give their kids hepatitis B vaccine because they're not sexually active. They think that, you know, my kid's not having sex, they don't need hepatitis B. But you would be surprised that in daycare centers, the most common way for hepatitis to be transmitted between people at daycare centers is through bites. And what do children do? They bite each other all the time. So if you have a kid in there that's come from another country, and you would be surprised the number of positive cases of hepatitis B come from South America, from Eastern Europe. It's amazing. I never knew until I worked at the health department how many cases of hepatitis are walking around. And, you know, if you have a child in a daycare center with somebody else's child who has active hepatitis and they get bit, or if they, you know, put things in their mouth and you know, your kid picks it up and puts it in their mouth. And I mean, it's pretty scary. Or somebody changes diapers and doesn't wash their hands properly and stuff. So it's something to think about. It of course causes the yellowing of the skin. That's probably the main characteristic, is that you notice that you have yellow sclera in your eyes or your skin or something like that. The thing is that it's a major cause of liver cancer. A lot of people don't know that it is the #1 cause of liver cancer. And people don't realize that hepatitis B was the first anti-cancer vaccine on the market. It does prevent liver cancer because it prevents the disease that causes liver cancer. And the best way to protect is with hepatitis B. Now, it's usually given at birth at 1 to 2 months, and then it has to be given at or after 6 months of age. If it's given in a combination vaccine, like the Pediarix is a common vaccine that has the hepatitis B, and they follow the schedule 2 months, 4 months, 6 months, and then 12 to 18 months. The 4-month dose, when they get that hepatitis B vaccine, does not count. even though it's the third dose of vaccine, because it didn't follow that schedule where it was given at or after 6 months of age. So a lot of parents are like, my kids had 3 doses. Why do you want to give a 4th dose? Yada, yada, yada. Well, that's the reason why, because they've gotten 3 doses of Pediarix. And the 4-month-old dose didn't count. They have to get that 6-month dose for it to count as their 3rd dose of hepatitis B. Make sure that it's given at or after 6 months, and do not restart a valid documented series. That's a question we often get. So a person comes in and they haven't gotten a hepatitis B vaccine in 5 years. Do we restart the series? No. You just pick up where you left off and give that dose. All right, you never restart a valid series. If a baby, now in Michigan, pregnant mothers are supposed to be tested for hepatitis B to see if they have it. But, you know, we have people that, you know, because they are homeless or because they are living on the street or because they're choosing to deliver at home and not having prenatal care, these people are not being tested. And we did have, and what prompted this law was a number of years ago, a mother who did not receive prenatal care and delivered a baby. They didn't test the mother when she delivered, you know, when she came in at the time to deliver the baby. She had hepatitis B and passed it on to the baby, and the baby died. So after that, they made it a law in Michigan that all pregnant women have to be tested. And if they do not have prenatal care, they show up at the hospital, you have to presume that the mother is hepatitis B positive, and you have to treat the baby with HBIG and hepatitis B vaccine. So, and that's a precaution to protect the baby. All right. And all of that is followed through the perinatal Hep B program through the state of Michigan. And part of that is at the health department that, you know, they give us those cases and we are the legs that go out and visit those homes to follow up on those babies. And we talk to the family and we talk to the infected person and teach them how not to spread hepatitis B to other people in their home. Let's see. So let's see, blah, blah, blah. Make sure that high-risk adults are vaccinated. So that would be people that are have multiple sex partners. And what is considered multiple sex partners is that you have more than one sex partner in 6 months' time. That is considered multiple sex partners. Because again, you know, oftentimes, number one, people don't know they have it. So they're out having unprotected sex and they're spreading hepatitis in the community, or they're not telling you that they have it. My sister's husband's cousin got a divorce later in life. She was like in her late 40s, early 50s. And she decided to start dating again. And she met this guy and he was all that in a bag of chips, you know. So they started having sex and he didn't tell her that he had hepatitis B, and she caught it and died. And she was like in her 50s. So, you know, this kind of thing happens. When I counsel people about unprotected sex, I said, you know, what you need to know is that you're having sex with everybody they've had sex with. So even though, you know, you think they're all that in a bag of chips, you really don't know who they've had sex with. And what you need to know is that, you know, you're having sex with everybody they've had sex with, and you need to protect yourself. I mean, I remember going out and doing a young girl. I think she was 17, 17 or 18, very young. And going out, and she had been with one guy. This guy was, you know, the love of her life. And he was playing, and of course, he's not going to tell her he's playing. And she was pregnant, went in for her prenatal exam. And she said, I was having my exam, and she said that the doctor kept leaning over and looking at her. And she said, I was like, why does she keep looking at me like that? Because she did it a couple times. And then the doctor had to get up and tell her that she had HPV, you know, during her pregnancy. And, you know, how did she get it? She got it from her partner, who didn't tell her that he was out having sex with other people. So, you know, we like to believe that people are honest. We like to believe that and give people the benefit of the doubt, but really you have to protect yourself, you know, and you have to know when you're counseling somebody that this can happen, and unfortunately does all the time. So, let's see, blah, blah, blah. And here's the recommendation. The ACIP voted unanimously to recommend that hepatitis B should be given to all people through 59 years of age and people age 60 or older with a risk factor. And a lot of that has, and again, one of the things that they're finding is that old people still have sex. So it is a sexually transmitted disease. And you go to, like, HIV in elderly communities is like hopping, because people think, you know, they don't have to worry anymore about getting pregnant, so they're not using protection. And because of that, they're contracting STDs. Rotavirus. Okay, so this is one of the live vaccines. Rotavirus is the most common cause of infantile diarrhea. And in developing countries, it's fatal, because, you know, a lot of times these kids will get diarrhea and dehydrate to the point where they die. It's a very simple vaccine. There are two products on the market. There's Rotarix and Rotatec. Rotarix is 2 doses, and Rotatec is 3. Now, the important thing to remember about rotavirus is there is a minimum age to get it, which is 6 weeks. You cannot give it before 6 weeks of age. There is a maximum age for the first dose. So if you're starting the first dose, the kid has to be less than 14 weeks, 6 days. If the kid is 15 weeks old, he's too old to start the vaccine. Then if the kid, the interval, because it's a live vaccine, there always is 28 days or 4 weeks between live doses. That's something, write that down, called the live rule. If 2 vaccines are given that are live, so if you give like varicella and MMR on this, you have to give it on the same day, or you have to wait 28 days between doses. Because if you give one live vaccine on one day and say maybe a week later, you give that second live vaccine, the antibodies from the first vaccine will invalidate that second vaccine. So either you have to give them on the same day, or you have to wait 28 days between the 2 vaccines, or one will X out the other. Okay. So this is a live vaccine. There's 4 weeks between doses. And then the maximum age for the last dose is 8 months, 0 days. So you're not going to give this to a child at 9 months, 10 months, 12 months, you know, you're done at 8 months. Don't give it after that. If you do give it, it's considered an error and you have to report it to VAERS. We'll talk more about that too. So follow the minimum and maximum age intervals for these vaccines. If both brands are available, continue to use the same brand. So don't mix. They're not interchangeable. They're different. They both protect against rotavirus, but they're different vaccines. So it's not where you can give like Rototec one time and Rotarix the second. You should give all of Rototec or all of Rotarix. You shouldn't mix and match. If for whatever reason, maybe a kid comes from another practice and they started using the Rototec, and you only carry Rotarix in your office, then you would give them Rotarix, and that would be 3 doses. You want to give 3 doses if you have to, you know, compensate for somebody's incomplete record. They're both given orally. That's important to remember. Remember, I told you somebody decided to mix it up and inject it in a kid's leg. It may be given before or after the shot. Do not repeat regurgitated doses. Now, this is another thing to remember about live vaccines. So, you know, when you give vaccines to kids, you're going to have kids fight. I can guarantee you're going to have fighters. And sometimes because they're fighting you, you know, the needle is going to come out and squirt on the floor or whatnot. So if you gave a live vaccine, you're going to say, you're going to say they got enough. You do not repeat any live doses. If it's an inactivated vaccine, repeat it. So, but if it's a live vaccine, you just have to say, you know what, I believe that enough got in the kid, we're not going to repeat it. Does that make sense? You look like
No, I get it.
you get it. Okay. All right. So you may give food or fluid after you give vaccine. And what they recommend is that you do the Rotavax first, because it has sucrose in it. And sucrose, according to research, it has pain relieving components to it. So if you give it to the baby, they're not going to cry as much when they get their shots, because the sucrose in the rotavirus is going to give them some pain relief. Okay. And make sure that you drop the applicator tube in the sharps container, because it's a live vaccine. So you want to make sure that you're disposing of it in the sharps container. That is the biologic hazard thing. You know, you don't want to throw it in the garbage can and let the poor little janitor get sick. Okay, the next thing, and again, you have a quick looks on rotavirus, and it tells you if you have a kid that comes in that started the vaccine with one brand and is now you have another brand in your office, how to deal with that, how to determine that. The next one is Hib, Haemophilus influenza B. This is probably one of the most common cause of bronchiolitis for babies. And as you can see, it has pretty nasty consequences. Sort of reminds me of meningitis and how, you know, it affects their limbs. There are 2 products on the market. There's Pedivax Hib and Actib, made by 2 different manufacturers, and they're sort of like the rotavirus, where one requires 3 doses and one requires 4. And the same thing goes that you can't interchange them. They're not interchangeable. So, you know, you should try to stick with the product that the kid started with. If the kid started with Actib, finish with Actib. If the kid started with Pedivax Hib, and with Pedivax Hib. However, if something should happen, what you're gonna do is you're gonna look at, this has been my Bible and saved, this is gonna tell you how exactly to give those doses. If you have a kid that comes in that's missed doses or has missing doses, this is gonna tell you how exactly to administer the vaccine. Because as they age, they will age out of the number of doses required. So the older they are, the less number of doses they need for this vaccine. So make sure that you read, it's in the package insert, but it'll tell you exactly how many doses to give. It is not given after 5 years of age unless there's an underlying medical condition. So if the kid has like some sort of immunosuppression, they may need extra doses of Hib. And we've also seen like people that get cochlear implants need Hib vaccine. They want the surgeon wants them to have Hib vaccine. It's crazy. And I guess it's because they may be prone to Hib after they get the cochlear implant or something. I don't know. It's weird, but that's one of the vaccines that they are going to ask that adults would get is the Hib vaccine, which is weird.
You do it after active school.
Yes, that too. Yes, yes, yes. Yes, we've had people request that after having their spleen, or people that have like a disorder that destroys the spleen, like their spleen is no longer functional. It's medical, it's not surgical though. So
type 1 diabetes with the safety.
Type
1 diabetes.
really?
Like, I just don't know.
No, I wouldn't think type 1 diabetes because that doesn't affect the spleen. So that's more the pancreas. So we've never really heard, I mean, we do recommend that children with diabetes have all of their vaccines, especially like pneumonia vaccines and stuff, because people with diabetes often end up in the hospital or on a vent if they get pneumonia. So in those instances, we would want them to have pneumonia vaccines.
So if after they turn 5 years old and they never took it, we would still give it.
Oh. Yep. Yeah, they age out of the vaccine. Same thing with pneumococcal. Now, pneumococcal, and I've put in several of the aids, the job aids for pneumococcal, because there's so many rules when it comes to pneumococcal, especially with adults now, older adults getting the Prevnar, and there's another one, there's Pneumovax and there's Prevnar. And they're two different types of vaccines. One's a polysaccharide vaccine and one is a conjugated vaccine. And there's rules about when you can give that because of insurance and all that kind of crap. So these job aids will help you determine when and how to give those vaccines to adults. So for children, it's routinely recommended that they get them, in the series when they get their other vaccines. So usually it's 2 months, 4 months, 6 months, and then 12 to 15 months of age. That's usually, the schedule and how that works. Now, pneumococcal vaccines, if you have people that need the polysaccharide vaccine and the conjugated vaccine, you never want to give them at the same time. So they have to be given separately, and there has to be a time span separating those two. It is preferred that you give the PCV13 first. That's the conjugated vaccine. And then 8 weeks later, if it's a kid, 8 weeks later, you give the PPSV 23, which is the polysaccharide vaccine. Now, for people 65 and older, you have to wait a year. And it's only because of insurance, because Medicare will not pay for 2 pneumonia vaccines in the same year. So it has to be given 1 year and 1 day later, which is stupid. There's no medical reason why it can't be given in 8 weeks, like it is otherwise. But because the insurance won't cover it, they say you have to wait the 1 year and 1 day. So, and make sure that you hang on to these, because these are going to save your life when it comes to pneumonia vaccines. So it is routinely given, like I said, at 2 months, 4 months, 6 months, 12 to 15 months of age. And it's important to ensure that younger children, less than 6 years, receive all of the doses or the catch-up doses. This is another one that is not routinely given after 6 years of age. Children age out of it. However, if you have a kid that is immunocompromised or has other underlying medical conditions that would make them prone to hospitalization or severe consequences of pneumonia, they can get it again, older for protection. And now there's a new vaccine out. It's got 20 different strains of pneumonia. It's called Prevnar 20. Now, I don't know, I haven't seen the package insert on that and whether that is going to be used on kids. I know they're using it on adults. Instead of the Prevnar 13, they're going to the Prevnar 20. And the PPSV 23 has 23 strains of pneumonia. And then the 13, the PCV 13 has 13. So that's the number of antigens, the number of strains of pneumonia that they're protected from. So for PPSV 23, you're going to administer 1 dose to all people 65 years and older. So if it's the first time that they ever have this vaccine, they show up at the office, they say, I want PPSV 23. They get 1 dose and that's it. All right. And then at least 1 year afterward, you're going to give the PCV 13. And if received, at least 5 years after the last dose of PPSV 23. And then a final recommendation of PPSV 23 is given. Now, the thing is that really you're only supposed to get 2 doses of PPSV 23. However, if it's given before age 65, like if you started it at age 50, and it's often given to people who smoke. So they got it at 50, and then they get another dose at 55. The last dose that they're going to get in their entire life will be at age 65, and that will be it. And the reason is you don't keep giving polysaccharide vaccines is because giving more than 2 or 3 doesn't work. They don't work. It no longer stimulates your immune system. It works off of the T cells. It's a T cell dependent vaccine, and you just don't get the response after 2 or 3 doses. It doesn't do anything. It's like giving them water, after 2 or 3 doses. So you don't give more than 2 or 3 in a lifetime. And polysaccharide vaccines overall, they don't use. They've pretty much been phased out because they're not very effective. They're T cell dependent, and that's why they don't work well. So you want to go with the conjugated vaccines. They work and they elicit a much better immune response. So remember that little blue portion on the schedule, that clinical decision making that there's like one little piece on that. So for the PCV 13, based on a shared clinical decision making you may give PCV13 to persons age 65 and older. That is not like a recommended vaccine anymore. It is recommended based on a shared clinical decision-making between your doctor and yourself. So if you go into the office and you have the risk of getting pneumonia and you're concerned about it, you have a conversation with your doctor says, okay, we'll give you the PCV13. Now, really, the reason that they did this is because we have done such a phenomenal job vaccinating children against PCV13 pneumonia. And pneumonia, children with pneumonia was the source of infection for adults. And because we have immunized children so effectively, they no longer are passing pneumonia on to adults. So what the CDC is saying, you know what? Adults don't need this vaccine anymore because we have done such a great job of vaccinating children. They're not passing pneumonia on to their adult grandparents or caregivers or whatnot. So they really don't need this vaccine. So now it's based on this clinical decision whether or not you should get the vaccine. So it's not routinely recommended anymore. Okay. So high risk indications, children ages 24 to 71 months who are immunocompetent with chronic lung, heart, diabetes, cerebral spinal fluid leaks, cochlear implants, or are immunocompromised. Those are kids who would receive that extra dose of PCV13. Because again, if they were to contract pneumonia, they would be the child that would end up in the ICU on event because of pneumonia. Persons 6 years age and older, for persons with a high risk indication and no previous dose, you can give one dose to people 6 years of age and older, again, for the same reason. And then PPSV 23 for children less than 6. First, you want to make sure that they've had all their doses of PCV13. Then you can give them the PPSV 23. And the reason they don't give a polysaccharide vaccine before age 2 is because that T cell immune system is not mature and it doesn't, your body will not react and build immunity to the vaccine if you give it before age 2, because their body is not, their T cell immune system is not mature enough to respond to the vaccine. So they have to be at least 2 years of age to receive that PPSV 23. And usually what we would do is give that to kids that have underlying medical conditions that would be at risk of pneumonia if they didn't get it. So they have the 13 strains from the PCV 13, and then the additional 23 strains from the polysaccharide vaccine. Okay. And then the vaccine for persons 6 through 64, it's based on medical risk. So, and you know what? I'm telling you, it's very, very confusing. So you really, really need to look at those job aids to help you determine. So high risk in an A group. So persons 19 through 64 that smoke cigarettes or have asthma, they would be qualified to receive that PPSV 23. Immunocompetent persons 2 through 64 with pulmonary, liver, heart disease, diabetes, and alcoholism. Again, these are people that if they got pneumonia, they would be the ones that you would be seeing in the hospital or the ICU. Asthma is not included as an underlying medical condition for persons 2 through 18 unless they're immunocompromised by high dose steroid therapy. And children, teens 6 and older with chronic liver disease or alcoholism, I hope to God that we're not seeing chronic alcoholism in children 6 years and older. But, you know, I suppose, didn't Johnny Depp say he started drinking when he was 11? I was like, I guess, I mean, it does happen, but you don't want to think so, right? So this is a higher risk group. So immunocompromised persons 2 through 64, you're going to give the first dose, you're going to give the PCV13 and then the PPSV23. And then the highest risk group, you're going to give, so it's high, higher, and highest risk group. That's going to determine how many doses and when you're going to give those doses of the pneumonia vaccine. So pneumococcal vaccination key points, when both vaccines are recommended due to risk, do not give them at the same time. Administer the PCV13 first, and then the PPSV23. Complete all of the doses of the PCV13 before giving PPSV23. The intervals between the 2 doses are based on age and risk factor. The intervals may be different if the PPSV23 is given first, because it's a polysaccharide vaccine. No more than 2 doses of the polysaccharide, the PPSV23, is recommended before the 65th birthday, and then 1 dose afterward. So 3 lifetime doses of the polysaccharide vaccine. And then if PCV13 was given before age 65, no additional doses are required. And why is PCV13 recommended? First, besides protecting against the 23 serotypes, when given first, PCV13 gives the best immune response. Just because a conjugated vaccine elicits a better immune response than a polysaccharide vaccine does at any time. So again, here's another chart to help you decide how to administer that vaccine. And it makes it a little bit easier to follow. And let's see, the ACIP unanimously approved the following 2 pneumococcal recommendations: age-based, blah, 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 series known. So they're talking about PCV20 or 15. If used, it should be followed by a dose of PPSV23 for 65 and older, and then adults 19 and older with certain underlying medical conditions or other risk factors should receive the conjugated vaccine first and then the polysaccharide. So the same principle applies. It's just the same information. Okay. Next one we're talking about is DTaP. And I'm going to give you a trick, because we see the most errors in administering tetanus vaccine of any vaccines out there. And it's because they're so much alike that they're confusing. So let me show you just quickly how this works. So there are 2 products on the market for, one is for younger children, one is for older children and adults. So there is DTaP. There's TDAP. There's TDDT. So do you know these are all tetanus containing vaccines? Do you know why some of the letters are capitalized and some are not? Any guess? It's the amount of antigen that is in the vaccine. So with DTaP, this is diphtheria, tetanus, acellular pertussis, okay? And this has a lot of antigen. This is required. Remember I told you about how it's given and it gives you that little kick each time? The amount of antigen in this, there's a lot. There's a lot of diphtheria, a lot of tetanus, and a lot of pertussis to elicit this immune response until you get it to the high titer where they're protected. Okay. As you get older, you don't need as much antigen for that response. So in this one, this is for adolescents. So this is 6 months, 6 weeks through 6 years is how that one is given. You don't give DTaP to children 7 years of age and older. Once they turn 7, they're going to go over to this one. The tetanus has a lot of tetanus antigen, a little bit of diphtheria, and a little bit of acellular pertussis. Okay, so this is for persons 7 years of age and older. All right. So this is the same principle. This one, TD, this is the one that you get if you step on a nail most often. You go in and get a tetanus shot. A lot of tetanus, a little bit of diphtheria. There's no pertussis in it. That's what's missing is the pertussis component.
Do they still actually,
Yes,
they
Oh, yeah.
do, just the tetanus
yes,
Yeah.
and the diphtheria?
yes,
Yeah. They don't make that toxin,
yes. The
the old toxin.
yeah, that's been off the market for a long time. And then this here, so there's a lot of diphtheria and a lot of tetanus. This is for 6 weeks to 6 years. And this is for children that cannot tolerate the pertussis component of the vaccine. There are some children that have a neurologic reaction to the pertussis components, and they have that high-pitched screaming and crying, and they sound like cats, and it's real scary, scares the bejeebers out of the parents. They don't want to ever vaccinate again once their kid goes through that. And it's a reaction, a neurologic reaction to the pertussis component. So if you have a kid that has that adverse reaction to that pertussis component, then you only give the tetanus the diphtheria and the tetanus part of the vaccine. You leave out that pertussis. But, you know, somebody needs to diagnose it that knows what they're talking about, because we have parents that, you know, want to come in and have single antigen vaccines, which don't exist. You know, they want everything separated because they think that if it's a combination vaccine, it's going to harm their kid, all this other stuff. You know, the vaccines today, most of them are attached to something else. Like, you know, the tetanus and the diphtheria are paired because they have to be paired. You couldn't have one without the other. They're linked together, and that's how it's always given. You can't give the vaccine without them being in that configuration. And parents, you know, read the crazy stuff on the computer and think that we should make everything single antigen, and, you know, we can't do that. That's not how it works. So,
She was asking about TB. We all get TB. So if you look on the app, you'll see a thing in there that tell you for healthcare providers, we will continue. Because we don't want to get that. But to the general population,
if you go to one of those urgent cares, they don't carry Tdap. They carry only TD because it's cheaper, you know, and, you know, they're going to give you the TD. That's a bad thing, is that, you know, parents take their kids to these urgent cares to get their school shots. The people at those clinics don't know the schedule, don't know that if they give just the TD, that it's going to have to be repeated, because the requirement is that they have a pertussis containing vaccine. So it screws up their schedule because, you know, they have to have that pertussis. Okay, so that little kid, have you ever seen anybody with pertussis? And oh my gosh, there are videos. If you go on YouTube and look up pertussis cough. It's whooping cough. That's what it used to be called. And it's also known as the 100-day cough. And basically that means you cough for 100 days. And that's no lie. And cough with such ferocity that people break ribs and end up with black eyes, and it's awful. So pertussis, we don't see it anymore so much because we've done such a good job immunizing. But again, because so many people are refusing vaccines, we're seeing an increase in the number of pertussis cases. The other reason that we're seeing an increase in pertussis is because in years past, it used to be DTP. It was DTP because it was whole cell pertussis. And that whole cell pertussis really caused that reaction, that neurologic reaction. And a bunch of parents brought a lawsuit back in the 1980s and all this other stuff. So the manufacturers actually retooled the vaccine and made it so that it was acellular pertussis. It's that outer shell of the whooping cough, the pertussis vaccine, that causes that reaction. So, and what they're thinking is that it doesn't elicit that good immune response that the DTP vaccine did, so that people don't have as much immunity to pertussis as they once did. And that's why they're seeing more pertussis. And we see, I mean, routinely, you would be surprised the number of cases we get reported on kids that are fully vaccinated, that have all 5 doses of the DTaP and the Tdap vaccine and will still catch pertussis. And it just is because, you know, their immune system, they don't have enough antigen. Their body didn't react and respond and build enough antibody to protect them from whooping cough, and they end up getting it. So, but it's not as severe as if they had caught it without the vaccine. That is pretty doggone crazy. You should do, look at YouTube and look up whooping cough. It's amazing what can happen. So DTaP is for children aged 6 weeks through 6 years. You don't give it after age 7. If you do give it, you are over immunizing. You're giving more antigen than is needed for a child 7 years of age and older. Now, what happens if you give Tdap to a kid or a baby? What happens? The Tdap has all the antigens, but what happens? Do you know? You're under immunizing because there's less antigen in the Tdap. You have to revaccinate them. So that would be like if you gave the DTaP to an older kid, you would not have to repeat the dose because the kid got more antigen than what they needed. But if you give Tdap to a younger kid, you're going to have to revaccinate them to make sure that they get the amount of antigen they need to elicit that immune response. All right. Let's see. So they recommend always that you follow the schedule because, you know, that's what we have the data to support. You know, we can go to the clinical studies and look at the data and say, if you get, you know, if you did it by this schedule, this is what's going to happen. Whereas if you don't follow the schedule, we don't have the data to support that information. So you should always follow the schedule. Make sure that you use MICR because MICR is going to help you. Now, MICR is not perfect. I have to say that. It's a wonderful tool, and it really is great to have. I mean, we're very lucky. Not every state has a registry like that. So there's a lot of states that are still using paper schedules and looking at it and trying to figure out what the kids need. So we're very fortunate to have MICR, but you have to know your schedule too, because sometimes it's a computer, it's a program, and it makes mistakes, you know, every so often. Like MICR is like an old farmhouse that they keep building on. It's an old system and they just keep putting a new addition on it and they build onto it and here and they put something here. So after a while, when they do an update on MICR, if they do something here, it messes the whole system up. So on Wednesdays is when they do the updates. On Wednesdays is usually when you see all the mistakes, and then the techs are in there fixing everything because, you know, whatever they did messed up the rest of the program. So it happens every Wednesday, I can tell you. So the, you know, the QI reports can help you recall kids that need vaccine. I mean, it's a great resource. It's important to assure that the kids have a complete series. And what is a complete series? They have 5 doses of DTaP following the routine schedule, or they have 4 doses of DTaP with the last dose at or after 4 years of age. So that's how you know if the kid is up to date. That is the standard. Now the Tdap is routinely given 1 dose at or after 11 to 12 years of age. And you should try to catch kids up if they don't have that dose. And to ensure protection, give 1 booster dose of either TD or Tdap every 10 years throughout life. You know, tetanus is one of those things you're never going to get away from. It's not something that we're ever going to be immune to because it's a bacteria in the soil. And, you know, after years and years go by, your body, you know, your immunity can wane and make you vulnerable to tetanus. So it's not something that you want to get. There is also an article, write this down, I want you to go look at it. There is a parent, you know, because again, we've done a great job of vaccinating. We don't see tetanus routinely. However, in Oregon, a couple years, I think it was 2018, there was a family that are living on a farm. They're organic farmers, don't believe in conventional medicine, didn't get their kids vaccinated, yada, yada, yada. The kid fell and whacked his head and needed stitches. The parents stitched the kid's head. About a week after that, the kid started showing signs of tetanus. Now, usually, if a person starts showing signs of tetanus, you're dead. You know, it's something that is rapid and you can't reverse it. So these parents then, this kid was airlifted to a children's hospital, spent 28 days in ICU. They had to keep the room dark. No sound, no light, because any stimulation would make this kid convulse. He had muscle spasms. You know, I don't know if you've seen tetanus, but it's, you know, every muscle in your body contracts and they end up like in a C, you know, because their head almost touches their feet. So this kid, they kept him in the ICU. He was on a vent. They had to give him all these medications, all this stuff. They saved his life. He lived. $800,000 later. Okay. The parents are going to pick the kid up and take the kid home. They wanted to give him a tetanus shot. The parents refused. So look it up. It's a big article in there about this whole, and I mean, for 40 years, we haven't seen a case of tetanus in the United States. And now because people are not getting their kids vaccinated, this is what's going to happen. We're going to see these diseases coming back. You know, these diseases, because we've done a good job, we don't see them here, but it doesn't mean that they're not endemic elsewhere in the world. Most of them are. And all it is a plane ride away. People get on airplanes, they don't know they're contagious. They fly on the airplane, they come here, and then all hell breaks loose. So just so you know. Tdap can be administered regardless of the interval since the last tetanus or diphtheria toxoid containing vaccine. So basically what that means is the kid stepped on a nail in the summertime and went to the urgent care and got TD, but he still needs Tdap. So he can go regardless of the interval. So he doesn't have to wait 2 weeks, 6 weeks, 10 weeks, nothing like that. You can go in the next day and get that if you need it. But the thing to remember is that if you have to give a Tdap vaccine after a kid's gotten a TD, make sure to tell them that the kid's going to have a pretty good local reaction. They're going to have a red arm. It's going to hurt, you know, because you've just primed that pump and now you're putting antigen in there and the body's going to know it. So it's going to react to that antigen. So just so they know what to expect. Catch up children 7 to 10 with an incomplete. So if the kid did not have 5 doses following the schedule or 4 doses with the last dose after 4 years of age, you're going to give them a dose of Tdap to catch them up. And then use TD or Tdap for any additional doses that are needed. So if the kid, the first dose you should give is the Tdap because we really want them to have the pertussis protection. And then if they come back, they need more doses, then you can use the TD or the Tdap. But the first dose should be Tdap to ensure they get that pertussis protection. Children who are 7 and 9 who receive Tdap inadvertently or part of a catch-up series should still get the 11 to 12-year-old because, you know, initially the rule was 1 dose of Tdap in a lifetime, you don't ever get it again. But now they're starting to use it. And I think eventually that will take the place of TD, that Tdap will actually be the vaccine, the preference, just to make sure that people are protected against pertussis. Now, you know what cocoon means, right? You've heard that term, cocooning. The strategy for the Tdap, for adults getting Tdap also, is to cocoon children, younger children, who cannot have a complete series for whatever reason from pertussis. So a baby, right? They're not protected until they're not considered complete until they have those 5 doses. So how long does that take to get the 5 doses? It's the entire first year. So children under age 1 are vulnerable to pertussis, and pertussis for children under age 1 is deadly. Children die. There is a lady that came and spoke to our group. Do you notice those bulletin boards, I vaccinate? She is the source of this, and her name is Veronica McNally. Veronica was a vaccine hesitant parent. She's a lawyer. Her and her husband are lawyers. They weren't totally against vaccines. They just didn't want to follow the schedule. So they were following Dr. Sears, who is this guy out there. He has a book and he's telling people, don't give your kids the vaccines. Don't follow the schedule, yada, yada, yada. So she was following that. So what happened, she was out working in the community. She had an infant, baby girl. She had a 2-year-old and a 4-year-old boy. Out working in the community, she caught pertussis and brought it home to her family. And her baby was 13 weeks old. With no vaccinations at all. Her 2-year-old was partially vaccinated. Her 4-year-old had most of the vaccines. The 4-year-old didn't get sick. The 2-year-old got it. The infant got it. The infant died. Franny died. And she was 13 weeks old, and Veronica was shocked. She, didn't realize that children will die from pertussis, and that she should have been vaccinated during her pregnancy, which she was not. And how important it is for your children to be vaccinated according to the schedule to protect them from these diseases. So because of her grief and her loss of losing her beautiful baby girl, and that baby, oh my God, that baby was adorable. She began this campaign of educating parents about the importance of vaccines. So that is her website. You can go on there and read about her baby girl. There's pictures of her baby on that website. And she's also the one who, through funding, raising money, she's gotten grants and stuff, has begun this I Vaccinate campaign. So when you see those commercials or those bulletin boards, think about Franny, because that's why Veronica is doing this, is for her baby girl who died from pertussis. And people just don't realize, the reason that, we didn't just make these vaccines because we had nothing else to do. I think I'll make an MMR vaccine today because, I have nothing to do. These were diseases that killed children. If you go to a cemetery, an old cemetery, walk around. Look at the gravestones. They're from children, babies, because babies, when they got these diseases, died from these diseases. And that is why, when parents were losing their children, there was an outcry for the doctors and scientists to come up with a vaccine to protect the children. So, and I think that in America, we've become very complacent because these have been available to us, and we have not experienced losses of children. And I was telling Bud before class, my mother had me late in life. So I grew up hearing, my mother was born in 1915. And I grew up hearing about children who died from vaccine preventable diseases. My mother's aunt, my grandfather's sister, had 3 children that died in a diphtheria outbreak. And diphtheria was called the strangling angel of death. That was, if that gives you any picture of how people died from this illness, I can't even imagine going through that and experiencing that as a parent. And, people lost multiple children. It wasn't just one. My aunt lost 3 babies. So, I fear for our future in America if we continue with this trend of not vaccinating our children, because again, these diseases exist. They're going to come back. It's just a matter of time. So anyway, this is the whole idea about giving Tdap to pregnant women and to their family members, is to provide cocooning, to protect that unprotected infant that has no immune system, to keep them from severe consequences of pertussis. So the rule is a dose of Tdap is given during every pregnancy. Even if that person is pregnant every year, you would still give that dose of Tdap. And you want to give it at like 27 weeks to 36 weeks, because that is the optimum time when the mother is transferring her maternal antibodies to the baby. That way, the baby has some protection, not a lot, but some is better than none. And then you're going to give them the DTaP vaccine, which is going to give them more protection as they get older. if Tdap was not administered prior to or during the pregnancy, give the Tdap immediately postpartum. Even if they had a tetanus shot last year or a Tdap last year, you still want to give that, because if the mother is breastfeeding, or if the mother should be in the community and come into contact with somebody with whooping cough, they will not take that home to their infant baby. The whole thing is to cocoon that infant. Make sure anybody that has contact with that kid, adult family members, other siblings, that they're up to date on their vaccines so that they don't infect that baby with pertussis. And anybody that wants to see that kid should have the Tdap vaccine at least 2 weeks before coming into contact with that child. And children less than 7 years of age, hopefully they will have a complete series. Now, this is one of the ones where any brand of DTaP or Tdap is interchangeable. You can give them to prevent errors. And, that's the other thing, is that this is the little trick I tell people, because it looks so similar by name. So DTaP, D-T-A-P, and Tdap, T-D-A-P. So what I tell you, if you can remember teeny bopper or teen or tween or anything like that, that will help you to remember that you use Tdap for tween, teeny bopper, you don't use DTaP for older kids and vice versa. So hopefully that helps you to remember, because in offices, that's one of the biggest mistakes that we see, that they're using DTaP for older kids and Tdap for younger kids.
Well, I work in an occupational setting, so I'm not in really healthcare. But we were told years ago that the only thing that was available was Tdap, when they switched it. So we would just give tetanus with, diphtheria. We wouldn't give Tdap in our environment. But we were told that was the only thing that was available.
I think eventually that will be the only thing that they're giving, just because they want people to have that pertussis, being that, we're seeing that upsurge in pertussis and whooping cough cases. And every year when the kids go to school, boy, I'll tell you, we get multiple reports of kids with whooping cough. So let's see. Okay, inactivated polio. So it used to be an oral vaccine. They used to give oral polio, and they do still give oral polio in Europe and in Japan and other countries. They don't give it here. The reason that they don't give it here was about 2000, the year 2000. What they determined is, over the millions of doses that kids would get every year of oral polio, there would be about 8 cases of polio coming from the vaccine, where a caregiver was changing a kid, because it's excreted. Polio is excreted in the feces. So people are changing diapers or wiping butts or whatever, and then not washing their hands, and then inoculating themselves, and they give themselves polio. So there would be about 8 cases every year of that happening. And because that happened, they opted to go to the all injectable polio, because this is an inactivated vaccine. The live vaccine, would give you the polio, but the inactivated vaccine will not. So that is why we are on the all IPV, the injectable polio schedule here. So it can be given IM or sub-Q if it's just polio. If you take polio out of a vial that's just polio, you can either give it sub-Q or IM. If it's in a multi-dose product, like Pentacell or Pediarix, you have to give it IM because you have to give the other components IM. The fourth dose should be given at or after 4 years of age. If they did not get the fourth dose at 4 years of age, they have to get a fifth dose. After that, they're done. That's it. You never give another dose. Now, you have to have 6 months between the next to last dose and the last dose. So if there's like a fourth and a fifth or a third and a fourth dose, whatever, there has to be 6 months between those doses for it to count. If it's given sooner than 6 months, it's an invalid dose. So, these are the little nuances you have to remember about, and only by giving vaccine are you going to learn these things. I've been given vaccine for 20-something years. So, I know the schedule, but, in time, and that's why it's so important to use these job aids until you remember these things, because it's a lot of information. If somebody comes from overseas and they've only had oral polio, they're going to need injectable polio when they get here. And that is because as of 2016, they removed a strain of polio. It used to be a trivalent, three different strains of polio in the oral polio. Well, they've eradicated one of the strains of polio altogether. They've not seen a case in I don't know how many years. It's been years. So they've removed it altogether from the vaccine. So what is available now has 2 strains. It's a bivalent dose of polio oral. So if somebody comes here, the United States does not recognize that as a valid dose. They have to have a dose of injectable vaccine, and then they will be considered complete. So when you have those kids coming from out of the country and you're looking at their records, and I mean, you wouldn't believe the number of doses, especially in Mexico. They give that vaccine like candy down there. I mean, I've seen kids that have like 10 doses of polio. I'm like, holy cow, why are you giving all this polio? But I guess, they're trying to protect kids because it's something that's in the water. It's contaminated water. And, I suppose there's contaminated water in Mexico from what I've heard. That's why they tell you don't drink the water, right? Okay, the next thing we're going to talk about is hepatitis A. This is something that usually is transmitted fecal oral. The sad part is that a lot of restaurants, there were a lot of restaurant workers in restaurants. People were visiting restaurants and getting hepatitis A from it, which when you think about that isn't very comforting to know because it is fecal oral.
It's surprising the areas too of the restaurants, like Western Field and things.
But-
My favorite restaurant, it happened to downtown.
Yeah.
But that's because the restaurant workers, the servers, are engaging in activities that increase the likelihood that they're going to contract hepatitis A. It's very high in men having sex with men, in people who use drugs, illicit drugs, people who are homeless. And that's, and I hope you don't take that to mean in a judgmental way. It's a lifestyle, and when you don't have access to facilities to take showers and, you're not going to be clean and stuff like that. So, it happens. So, it has similar symptoms as hepatitis B, causes yellowing in the skin. The thing is, the outbreak that we experienced with that hepatitis A, for whatever reason, was very severe. typically hepatitis A doesn't kill people. I mean, people get sick and they get very sick, may even have to be in the hospital, but they recover. With this particular strain of hepatitis A that was circulating, people were dying, and they were dying a lot. Also, it was on truck routes. It followed truck routes, which is, I mean, the things that was going on with that outbreak, it was pretty crazy. We knew that if there was a truck route somewhere, where people were staying at truck stops and different things, that's where a lot of those cases. Yeah. Yeah. So, it is sexually transmitted. So, I mean, that's another one of those things where, people should be wearing condoms, but then again, So this is a vaccine that is IM, has to be given IM, 2 doses. It starts at 12 months, so you can't give it between, before 12 months. And there has to be 6 calendar months between the 2 doses. If it's given before that 6-month interval, it's invalid. So there has to be that 6 calendar months between those doses. If somebody is traveling, okay. How do you make that go? Stop it. All right. I'm like, I touched something. Okay. If a kid is traveling, they can have the vaccine 6 to 11 months, but it doesn't count as a valid dose. And they give it as a precaution to protect the kid when they're traveling outside of the country to areas where hepatitis A is endemic, like South America, Mexico, stuff like that. And it won't count. It won't count. You have to revaccinate and get the 2-dose series beginning at 12 months. But it's preventative. We're hoping that it will protect the kid. Vaccinate children 2 to 18 without 2 valid doses, and vaccinate adults at high risk. So there's guidance for that, for the hepatitis A, because of this particular, it actually originated in California. It's the same strain that was, I think, found, and I want to say in San Francisco. And for whatever reason, and they don't know why, it appeared here and started circulating here. You would think that if it was there and somebody traveled, that it would make its way in different states, but it didn't. It was like it started there and then it appeared here. Very weird. There's a couple of products on the market. The Havrex and the Vacta is the single antigen hepatitis A vaccine. And they are licensed for, and this is, okay, so this is dumb. And why they did this, I don't know. But what happened was when they did the licensing for hepatitis A and hepatitis B, the licensing for hepatitis B is birth through 19 years is the pediatric formulation. And then once a person turns age 20, then you give the adult product, right? Hepatitis A, this is Hep B. So with hepatitis A, it's 1 year through 18 years, and at 19, they get the adult formulation, which causes tons of errors and tons of confusion because people want to have the same schedules for, but it doesn't work that way. And again, it comes down to those clinical trials and who they tested that vaccine on. So, and why they did it that way, I don't know. But that's how it is. And that's, you have to remember that for the hepatitis A and hepatitis B vaccines, that the adult formulation starts at age 20 for hepatitis B, and the adult formulation starts at 19 for hepatitis A. Okay. Now, and you can see that it's on there, the schedule. Let me talk about this Heplisav. This is a hepatitis B. And may I take this?
Yeah.
I run out.
Sure.
I always get very, very dry mouth when I talk too much. So, excuse me, Heplisav is a new product, and it's one of the vaccines. It has an adjuvant, and it's an adjuvanted vaccine. And adjuvant, what it is, an adjuvant is something that gives you a little extra boost. ADJUVENT, I believe that's how you spell it, adjuvant. Basically what it is, it's an aluminum salt that they add to the vaccine. And it causes your body to have a stronger immune response to the vaccine. Now, have any of the ladies in here had the HPV vaccine? Have you had it? You've had it. How did your arm feel afterward?
I had a lump in my arm and like a painful reaction for like 3 months.
That's because HPV is an adjuvanted vaccine. It has an adjuvant in it. And the purpose of the adjuvant is to really get that immune response, to elicit that strong immune response. That's why HPV vaccine has a 90% efficacy rate in preventing the cancers caused by the HPV, the human papillomavirus. The same thing is with this Heplisav. Now, I don't know, I think Bud probably knows this, but for a long time, people, when they would enter nursing school or other schools, they would have a titer drawn of their hepatitis B, and there would be nothing. I'm a non-responder. When I had my titers drawn, it was Zippo. And I read an article somewhere, I don't remember, but what they found is that there are some people genetically who do not respond to the hepatitis B vaccine. Their body does not recognize the antigen and doesn't build immunity to it, no matter what they do. However, they've come out with Heplisav, and guess what? You get Heplisav, you're going to get a 90% efficacy with it, but your arm's going to feel like it's going to fall off. You know, there's a lot of pain. You have that strong reaction. The same thing goes for the vaccine Shingrix, that shingles vaccine that they're all talking about, the wonderful shingles vaccine. Yeah, they warned about grade 3 reactions, that some people's arm was so sore, they had such a strong reaction that they actually missed work because they couldn't go to work after they got the shot. So that is something to keep in mind with these adjuvant. There's also a flu. So there's the HPV vaccine is adjuvanted. The Heplisav is adjuvanted. There's a flu vaccine and the Shingrix that are all adjuvanted. Whenever you hear that, it's an adjuvanted vaccine. You have to talk to people about the reactions, that they can expect to have these reactions. I mean, not everybody has a severe reaction where their arm's going to fall off and they can't go to work, but it's something that you should tell people to expect, because it's kind of shocking and surprising when you have the vaccine and you end up like that. So make sure that you counsel people about that. Let's see, Twinrix is a combination vaccine, is used for ages 18 and older only. And that's a hepatitis A, B combination vaccine. We see this a lot in, they use it a lot like in drug treatment facilities and clinics that deal with LGBTQ people. It's something that they're trying to get people to get the vaccine and get up to date with the vaccine quickly. This is something that can be given in 2 doses. The Twinrix is a 2-dose. It's given today, and then in 6 months you get the 2nd dose. So it's something that we can give quickly to cover people and protect them in a short period of time. Human papillomavirus. Human beings, warts is a very common virus. It's the most common virus known to human beings. Everybody has them at some time or another. Either you've got them on your hand, you got warts on your hand, you got them on your feet, right? You got plantar's warts when you took showers in high school. Everybody at some point is going to have these warts. The thing with the human papillomavirus, this particular virus chooses mucous membranes to colonize. That's where they live. And the thing is that there are strains of this virus that cause cancer. A friend of mine, her daughter, it was so sad. She had a baby. And after she had the baby, she wasn't recovering well and she kept going to the doctor. And for whatever reason, and I can't imagine why, they didn't do a pap test. She had cervical cancer from HPV and died. She was 32, left behind a 2-year-old. It's crazy, you know? So a lot of times the infection is asymptomatic. People don't even realize that they have it because there are no symptoms. The only way that it is detected is through a pap smear. You know, even if it's subclinical, you can still spread it from person to person. So if a male has it and gives it to you, I mean, so it's really important that males and females get vaccinated, because even though men don't have cervixes, this particular virus causes anal cancers and oral cancers, neck and throat cancers. You know, Farrah Fawcett, do you know who Farrah Fawcett? Anybody? Older people would know. She was a model back in the day. She was so pretty. She died of anal cancer because of HPV. And Michael Douglas, you know who Michael Douglas is, right? He's married to, what's her name? I can see her face. I just can't think of her name. He had oral cancer and throat cancer from it. So, and it can be pretty severe, you know, people can die from it. So, you know, and this is a very simple fix. Get the vaccine, right? I did it again. How did you make it go away?
Oh.
There we go. I got it. I guess I'm touching something on this mouse. So the best protection is get the vaccine. So even without having sexual intercourse, you can still get HPV infection by intimate skin-to-skin contact. So even if you never have intercourse, you can still get HPV. By age 50, at least 4 out of every 5, or 80% of women, will have been infected with HPV at one point in their lives. which means it's prevalent. It's across the board. It's pervasive. HPV is very common in men. But again, men don't have cervixes and don't get pap tests. So a lot of times they don't know that they have it. And it works best when the entire series has been given before somebody is exposed. And that's why they start at age 11 to 12. And what the recommendation is too, is that if you have somebody that you think may be in a situation that puts them at risk of sexual abuse, that you can start the vaccine at age 9 so that they have protection against HPV. There are 9 serotypes in the vaccine. And it really does. It's age 9 through 45. The routine age is 11 to 12. Now, the way that it works is that if you start before age 15, getting the vaccine, you only need 2 doses, 6 months apart, because it's so effective that, you don't need those 3 doses. But after age 15, at 15 or older, then you're going to need all 3 of the doses. It's not recommended during pregnancy, just because, in the clinical trials, they don't include pregnant women in any kind of clinical trials. So there is no data to say if it is or isn't safe. There's nothing, except that if people get the vaccine during pregnancy, it's reported to VAERS, and that information is captured. And that's how they come up with that data for pregnant people. It used to be there was a 2-valent vaccine out and a 4-valent, HPV4 and HPV2, but they have discontinued them. But there still may be people out there that have had those vaccines. If you see them, just finish the series with the HPV9, but you don't have to give additional doses. So if they've had 3 doses of those 2 vaccines, they're good to go. The 2-dose series, if they're less than 15 years of age, if they start after 15, it follows the same schedule like as hepatitis B. So it's like 0 is the first dose, 1 to 2 months is the second dose, and then 6 months is the last dose. And persons with a complete HPV series are not recommended to receive additional doses. And I've included some handouts about talking to parents. This is one of those vaccines that parents get very upset about, because they believe their kid is not sexually active and doesn't need the vaccine. Some of the culture, we've had a lot of pushback from Arabic culture, because they believe their daughters aren't going to have sex before marriage and stuff. And I'm like, well, what about the boys? A boy can give HPV to his wife, even if she's a virgin. I mean, it is what it is. So we try to, educate parents about the importance of getting this vaccine. You do the best that you can, but it is an anti-cancer vaccine, and they've seen a dramatic decrease, even with the amount. They said that even though not all kids are vaccinated, I think there's a 30% vaccination rate across the board. They've seen a 40% decrease in the number of cases of cervical cancer already, even with that low threshold of vaccination. So it really does work, and it really is effective. Meningitis. So meningitis is a rare disease. It is not seen very often, but when it does happen, the onset is very rapid and the decline is also very rapid. And meningitis is a disease that you give the vaccine, and the vaccine wanes over 5 years. So you really need to repeat that vaccine every 5 years for people that have asplenemia or some other immunocompromising disease that they would require that vaccine. It is spread person to person through respiratory and throat secretions. We had a young woman come and talk to us. Jamie, she had a German name, something or other. She contracted meningitis. She was 19 years old at school, away at college, and she lost all of her fingers on both hands and both of her legs below the knee. She went on to be a para-Olympic. She did bicycling. I think that's called para-Olympics or something, you know, it's people that are handicapped anyway. And she has a pretty interesting story on YouTube too, if you ever want to look at it. So for the best protection, you follow the schedule, you give that dose at 11 to 12, and they only give the vaccine during the time when the kids are most vulnerable. So it's when they're sharing water bottles and lipstick and drinking after each other and kissing and things like that. And it's a disease of close contact. You know, it's not something, you know, you see it in barracks, you see it in dorms, you know, and in middle school and high school, because kids are engaging in those high risk behaviors, sharing things and things like that. So you're going to give the first dose at 11 to 12 years, and then you give the second dose at 16. And then unless they travel outside the country, they'll never need any more meningitis vaccine. It's just to protect them during that period of time when they're most vulnerable to it. Kids that are going away to college should at least have one dose at age 16. So, you know, it gives them protection while they're living in dorms. If they commute, it's not a risk, but if they're living in dorms, it is. And then it's not recommended to healthy people after age 22. So as you can see, our completion rate in Michigan isn't very good for meningitis vaccines. So the vaccine that is here, the one they're talking about, is the MenACWY. And that is the strains, the ACWY are the strains that are in that particular vaccine. There is, these are the risk factors. And then there's two different products. There's Menveo and Menactra. They have found that if you're using Menactra, it could interfere with other vaccines like the DTaP, or PCV13. So they're telling you that if you have people that are on those vaccines because of an underlying medical condition, that you would want to use the other product. You would want to use Menveo and not Menactra because of the immune interference with Menactra. There's another product out, it's meningitis B vaccine. This particular vaccine, if you remember a number of years, there was an outbreak at one of the Ivy League colleges out east, and they had a Princeton, I think it was, a bunch of kids came down with meningitis and died, and it was meningitis B. And they brought this vaccine over from Australia. We didn't even have a vaccine here in the United States for meningitis B. Now, our vaccine has ACWY. It does not have B, but this B is pretty serious. There are two products. One's called Trumemba and one's called Bexsero. These are not interchangeable. If you start with one, you have to finish with one. You shouldn't be given Bexsero and then Trememba or vice versa. The same brand must be used, and you may give Men-B the same time as you give the Menactra or Menvio. It's not, you would give one in one arm and one in the other. And then Men-B, you're going to give for people 10 years and older, you're going to use Men-B for people with these underlying medical conditions. And then based on your discretion, again, this is one of those clinical decision that you make with your physician. Your physician says you're going away to school, this is probably a good idea, then you would get the Men-B. Okay. My son-in-law worked at Lifetime Fitness, and there was a young girl that was working with him. This happened about 5 years ago, and she contracted meningitis B and died. And this is how rapid it is. You show symptoms on Tuesday, you're dead on Thursday. And that's exactly what happened. She started feeling sick on Tuesday, and on Thursday she died. So that's why, we tell people, even though it's rare, when it happens so quickly. And the symptoms are vague. They have flu-like symptoms. And, then things start progressing and getting worse. Like this Jamie person, she started noticing like she had petechiae all over her body, these red spots. And then she had like this horrible headache. And that's what she called her sister and said, come and get me. I need to go to the hospital. They took her to the hospital, and she got there just in time. They saved her life, but she did lose all of her fingers and both of her legs. So it's, something that is not to be played with. It's very, very serious. Okay, we're going to talk now about the attenuated live vaccine, the MMR varicella, MMRV, rotavirus, and LAIV, which is flu mist. So this is the live rule, that the vaccines be given on the same day at the same time, or you have to wait 28 days. Because if you give them any time apart, the first vaccine given can interfere with the immune response to the other vaccine. So, anytime you're using a live vaccine, you have to follow that 28-day rule. Live vaccine should be given to a child or household member or a close contact of a pregnant woman and a person who is immunocompromised, because those people cannot get the vaccine. So you don't want the person to come down with the chicken pox and bring chicken pox home to an immunocompromised person or a pregnant woman. So that's the whole idea. It's that cocooning the most vulnerable people. MMR, varicella, and herpes zoster. Herpes zoster, as you know, is caused by chicken pox. And, if you get chicken pox, then later in life, you're prone to shingles, which they say about 80% of people as they age will eventually get the shingles at some point. So, and that's why they're pushing those vaccines. The old vaccine was a live vaccine called Zostavax. That's off the market now. That had like a 30 to 40% efficacy as compared to Shingrix, which is 90%. So you can see why, they would take that off the market. Of course, these diseases are still here. This is the number of cases that were reported. Of course, we didn't have a lot of anything like the flu dropped off to nothing, even with the coronavirus, because people were wearing masks and they weren't traveling. So, the key is that when you travel to countries where those diseases are endemic, you can bring those diseases back. And that's how those other diseases, the measles and stuff work. So mumps now, what they're seeing with the mumps is that a waning immunity, even though everybody gets 2 doses of MMR, as you get toward your adolescent years, that immunity wanes. And we're seeing a lot of outbreaks in colleges, college kids getting the mumps. So they're recommending if somebody should go off to college and there starts to be an outbreak of the mumps, that you go ahead and get a 3rd dose of MMR to protect you from those mumps. So, and again, like it says, these diseases have life-altering consequences, including death. It's no joke. I just read in the MMWR about a woman. She was like 40, I want to say like 46, 48 years old, that died from a complication of the measles that happened because she had the measles when she was a kid. And it's something that can happen years and years. It's an encephalitis, which is crazy. The measles, mumps, and rubella vaccine is routinely given at 12 to 15 months. Again, you give the first dose at 12 months, and then the next dose is usually given at 4 to 6 years, is usually when that's given. Adults that were born in or after 1957 should have 2 doses of MMR. And what they're saying is that people that were born before 1957 probably had the measles. I was born in 1956 and I never had the measles or the mumps. So I went ahead and got the MMR because I wasn't about to get either of those as a senior. It's like, nah, I don't think so. So this is that rule about people who have had 2 doses ending up getting the 3rd dose because there's an outbreak going on. And varicella is routinely given at 12 to 15 months, and then again at 4 to 6. And persons born in the United States in 1980 or later without proof of immunity or vaccination should get it. And they're assuming that if you were here before 1980, that you probably had the chicken pox. Now, if a person should come in to the office and the mother believes that they have the chicken pox, really, it should be tested to confirm that it is the chicken pox, because there's other rash illness that looks like chicken pox, and people can think that they have the chicken pox, but it's not. So if ever you have somebody that comes into your office and they believe they have chicken pox, you should do a swab and have it tested. Never just take the parents' word for it. And you have to report it. It's a reportable illness. This is what herpes looks like. Herpes or shingles is very, very painful. And sometimes even after the rash goes away, that pain can last for months. And they've had reports of people committing suicide from the pain. It's so painful. So, and what happens is that your immune system decreases because of whatever reason, and then you have this outbreak of shingles. So it's not a pleasant experience, and being that there's a vaccine, we sure do recommend that you get it. And it just shows you the efficacy of the vaccines. 2 doses of the recombinant Zoster vaccine are recommended in the prevention of herpes, and its confirmation to people 19 years of older who will be immunodeficient or immunodepressed due to disease or therapy. And surprisingly enough, you should see the number of people, young people, that are getting shingles. It's surprising. Influenza. Influenza, as we know, is an airborne disease spread by respiratory droplets. the recommendation is vaccinate every year. Get your flu vaccine every year. All people 6 months of age and older. Those are the 21-22 flu recommendations. I believe those are in here. I tried to put in some stuff that would be helpful to you. Influenza vaccination of people with an egg allergy, because that's always an issue. How to administer intramuscular and intranasal influenza. And that's because of that experience that we had with that flu mist. And then determining the number of doses. Because of the H1N1 vaccine and the pandemic, we want to make sure that kids are vaccinated. They get 2 doses of influenza vaccine the first time around, and then they get 1 dose every year, but they have to have those first 2 doses. Let's see. This is the 6 months through 8 years that need 2 doses, receive the first dose ASAP after the vaccine becomes available. And then the second dose should be given by the end of October. There's a minimum interval of 4 weeks for flu vaccine. So I'm trying to hurry. I know that I've kept you a long time. Pregnant persons should be vaccinated for flu. And no recommendation is made for revaccination later in the season who have already been fully vaccinated. So there is no recommendation for people to receive a second dose, even though over the course of a year, your immunity does wane. IIV4, this is the quadrivalent formulation of vaccine. That's usually, I mean, most doctors' offices now carry the quadrivalent. I mean, there is still some with the trivalent vaccine, but most of them is the quadrivalent. It contains 2 strains of A and 2 strains of B. And we like to give that because, you know, during the flu season, different strains circulate at different times of the year. So you might see the A strain circulating in the beginning of the flu season and then the B strain in the end of the flu season. So we want to make sure that everybody's covered for both to protect them throughout that year. The thing to remember about flu vaccine, it must be given IM. The same thing with hepatitis B. If hepatitis B is not given IM or flu vaccine is not given IM, it won't work. So you have to make sure that that's given IM. High dose, there's a high dose, and I don't know. I'm thinking about, well, the high dose is routinely given to seniors. And it's the same thing, you give it IM. I'm just thinking about, there's the adjuvanted, the Fluad. That's the adjuvanted flu vaccine that I was talking about. But there was one, I can't think of the name of it now. The one in it was given subcutaneously. It wasn't given IM. I can't remember the name of it, but I think it's not available anymore. And then of course, flu mist. And now because of that story, you'll always remember that you squirt half of the dose into the nasal, you remove the stopper, there's like a little spacer, you take that off and then you put it in the other nasal and you push in the rest of the fluid. So you give the entire applicator and you just remove that little spacer to administer that second half. But it goes 1 squirt in one nose and 1 squirt in the other nose. One year they made a preferential recommendation for flu mist, and that year was the worst year for efficacy for children. So they've never made another recommendation for flu mist. And then that algorithm that I gave you about how to decide whether or not to give the flu vaccine to somebody with an egg allergy. And basically what they've come up with and said is that, you know, They've given tens of millions of doses of flu vaccine to people with and without flu allergy, and they are egg allergy, and they've never really had an anaphylactic reaction to the vaccine, regardless of whether or not you're allergic to the eggs. So really, a person with an egg allergy, that is not a contraindication to receiving flu vaccine really anymore. There's still a lot of doctors that don't want to give it just because, but really there's no reason. There's never really been that much of a bad reaction to it. So this part is kind of confusing. However, let me say, some brands of vaccine for children, what they would do is they would make one formulation. It would be 0.25 ml, and that was for children 6 to 35 months. Once they turn 36 months of age, then it would go to the standard dose of 0.5. Now what they're doing is they're making it 0.5 across the board. They're giving the 0.5 to all kids 6 months of age and older, because it's very confusing. And what would happen inevitably, they would be giving the 0.25 to children older than 3 years of age. And then we would have to say, you got to call them back and revaccinate them because they didn't get enough antigen. So now they're going to the 0.5, which is, I think that's a better idea anyway. So this just explains the different brands because those are the ones that still use the 0.25 volume instead of the 0.5. Let's see. So this is more about that 0.5 errors, you know, yada, yada, yada. We really, it's a dumb thing to do when you do that with vaccine, because it confuses people and then they make mistakes. And, you know, again, the 2-dose recommendation, I gave you that little thing about how to decide whether or not the kid needs 2 doses or not. And it has to do with that H1N1. They want to make sure that the kids are covered for H1N1. And then make sure that you use those resources that I gave you. I don't want to talk about that. Okay, so now we go to the screening questions. So basically what you're going to do, again, you're going to, after you've assessed the record and decided what the kid's going to get, then you're going to ask the screening questions because you want to eliminate any contraindication that may exist. And you're going to chart whatever that is. Then you're going to educate the parent about what their kid is getting. And you're going to give them, by law, the federal government requires that you give them the vaccine information statement. So you have to give that to them because they have to have the opportunity to read it and then ask questions before you give the vaccine. So that's the law. And, you know, your doctor can be sanctioned, or you can be sanctioned if you don't follow that.
Most of us working in primary care, our EHRs get this.
Yes.
So you won't even be able to reach your order until you verify that this is happening.
These, you can print these off of the website. There's the website right there. And, you know, or the other option is that you can print them and laminate them and keep them in the room. And you just have to give the patient the opportunity to read the information and ask questions. That's what it's the informed consent notion, you know, that you're going to allow them to have that opportunity. These are wonderful resources. I use these all the time when I was in clinical practice. It's what to expect after the shots, and they have it for children and adults. And again, I really think, you know, parents think that if their kid runs a fever and their arm hurts or is swollen or red or whatnot, that they're having an adverse reaction. No, an adverse reaction is when you have anaphylaxis. This is a common side effect of the vaccine, but people don't want to get their kids vaccinated because they think that's an adverse reaction. So you need to inform people what to expect and how to treat it. So if they run a fever, they can use Tylenol or Motrin, put a cold compress on the arm, you know, whatever. But you have to give them some information. And, you know, try to answer their questions. The other thing is that people don't know enough about vaccines that when somebody asks them a question, they don't know what to tell them. So, you know, make sure that you understand enough about the vaccines that when people ask you questions that you can answer them. That's important. And then administer the vaccines. I've given you charts about using vaccines and how to use them. All these little colored resources here, these are great because it shows you exactly how to give the vaccines. The needle length and using combination vaccines. Combination vaccines are a great way to reduce the number of pokes. So if it has like 3 or 4 different antigens in it, it's 1 poke as opposed to 3 or 4 different pokes. So, you know, we recommend using the multiple antigen vaccines. So this is showing you on that little chart where to give it. Now you notice that red square where the PCV is and the DTaP. Those 2 vaccines should be separated because both of them cause a local reaction. And if you put them next to one another, then they have a large local reaction. And if that happens, the parents are very upset. So instead of a little round red mark, you're going to have a big round red mark, and you're going to have a parent calling you up and thinking that their kid has cellulitis or something, you know, because they're always on, you know, Googling something. So, you know, this just shows you how and where to place the vaccines. As they get older, you can use the arm in the back of the arm for any sub-Q. So if you have the injectable polio and they're getting that as a single antigen, you can use that in the back of the arm. The MMR and the varicella are sub-Q. They can also go in the back of the arm. So you can use the big muscles in the legs for the IM injections, and then the back of the arms for the sub-Q. In adolescents, you're going to put the meningitis in one arm and the tetanus in the other. So you can see the ACWY is in one arm and the Tdap is in the opposite arm. And that's the same thing, you know, it has to do with the reactions. Vaccinating during a pandemic, of course, you're going to screen for COVID. And you're going to use a face mask. I mean, these are things that are pretty commonplace. This is something to really think about and remember, SIRVA, shoulder injury related to vaccine administration. So you need to know that when you give an IM injection in the arm, you're going to go 3 fingers below the acromion process in the shoulder. If you go up too high, you're going to get into that rotator cuff. And I've actually known people that have had to have physical therapy because somebody got an injection, a flu shot in the rotator cuff. And this is a fast track to a lawsuit, I can assure you. So make sure that, you know, whoever is giving it, whether it's you or the medical assistant or whoever, understands that when you give that vaccine, you need to go 3 fingers below that shoulder in order to avoid that SIRVA injury. When let's see, when administering an IM, again, 3 fingers below, and you're going to go the thickest part of the muscle. And depending on the age and the weight of the person, if you have somebody that has a large arm, you want to use a longer needle. If you don't have a long enough needle, you're not going to get into the muscle tissue. So you want to make sure that if the person is heavy or has a big arm, that you're able to get into that muscle tissue. And then one thing to remember, people pass out, and especially adolescents. It happens, so you have to be prepared for it. And if you know that somebody is prone to passing out, you might want to have them sit or lay down when you're giving the vaccines to prevent somebody from passing out. We had somebody pass out one time in the parking lot. She hit the parking block and broke her jaw. So that was a lawsuit. Then afterward, after you give the vaccines, you have to, this is required by law, you have to record these elements. You have to record the date it was given, the date that the information statement was given, the publication date, because those vaccine information statements have publication dates on the back. So you look at the publication date on the back of that statement and you record it. That's what's in your EMR, is that publication date. The vaccine manufacturer, the lot number, and the signature and the title of the person administering the vaccine. And it's also recommended that you put in there the site and the route, so that if somebody has a reaction, that you know what you gave where. And then if an error occurs, which it can, assure the person, most of the time when people get vaccines, if you make a mistake, they're not going to die. They're safe. It's not like if you gave an overdose of heparin or insulin or something like that. And basically, what you're doing is just giving extra antigen. So they're going to have extra antigen on board. But you still have to record it exactly how it was given. So you're going to put it in MICR exactly how it was given, and then you're going to report it to VAERS. VAERS is the adverse vaccine, and I can never remember the acronym. Vaccine adverse event, I can't reporting system, I think I can never remember the acronym, but yeah, there it is. Vaccine adverse event reporting system, sorry. And you go in there and you report it, because what then happens, the CDC tracks that person. So if a pregnant woman gets a live vaccine, they track that person to make sure that nothing bad happened, or they record whatever happens. So then they have data and information on, well, we know, X number of people got live vaccine that weren't supposed to, and this is what happened. And then, make sure that you are a strong recommender of vaccines. Immunization resources, and that's it.
Thank you so much.
I'm sorry that it went so far.
You're right on the nose. 3 hours every run. But thank you very, very much.
Yeah.
Those of you not informed yet, those informed are noticed, you will get an immunomodulator component in that course, but no vaccines. I don't teach vaccines. If you had the immunology, I didn't teach vaccines last year. When we plan your whole curriculum, start to finish, we plan on this being your preparation for that. And that was a great job. Thank you so much. Very practical, but and it's complex, which is why I preach about always.
There was an evaluation in there. Can they fill out that evaluation? I do, just,
Won't take but a minute.
yeah, just a minute. And I'm sorry that I kept you so long. Hey. K-A-Y. I did. I did have Dr. Piper. Yeah.
Excuse me, I'm gonna take that mouse
Oh,
back
sure.
and turn off the Zoom.
Sure. Thank you.
Thank you.
She just retired.
Did she really?
Yeah.
Wow.
Was this faculty or something?
Yeah, Dr. Piper,
At Wayne?
Barbara Piper, pathophysiology.
Oh, I didn't undergrad.
You didn't do undergrad? Her husband, professor, too. Really? Yeah, I think he's taught the he was